Okay, well, it's 3 o'clock Eastern Standard Time here, so I think we're going to go ahead and start with the call. I just want to say good afternoon, everybody, and welcome to the July Community of Practice call. I'm Stephanie Hall, the Community Engagement and Partnership Specialist, and so we're so glad you can be here with us today. Before we get started, I just want to take a few minutes to introduce the CARES, our team, and why we're bringing this Community of Practice series together. So who is the CARES? Well, CARES is the Kidney Health Analytics and Responsive Emergency Support. Not only do we do emergency support, but we also support the community through community engagement, technical assistance, data and analytics, patient and family engagement, information sharing, and partnership across the country. Our goal is to bring people together, foster collaboration, share best practices, provide technical assistance and resources that help strengthen the kidney community and improve the care for patients living with kidney disease. So here's just a real brief overview of the CARES team. You may see, you'll see different members of our team, including community of practice calls at town hall meetings, webinars, and other care activities throughout the year. There are several of the CARES team on the call today that you might be hearing from a little bit later. So we're looking forward to working with all of you and continue to build a strong, connected kidney community. I also want to thank some of our CMS partners who have joined the call today. Many of them are on, so I want to thank them too for taking time out of their day and joining us. So why a community of practice call? Well, we know that there's a lot of expertise across the kidney community, and one of our goals is to create opportunities to bring that expertise together. These calls are designed to connect networks, providers, patients, partners, and other stakeholders so we can share ideas, best practices, lessons learned, and offer practical solutions that others can take back and use. This is meant to be a two-way presentation, so ask questions, you can share your experience and learn from one another. These calls will be occurring every month, and we'd really like your input. So at the end of the call today, you'll receive a link to complete your feedback. If there are topics you'd like us to cover or speakers you'd recommend, please let us know. We want this series to be driven by the needs and interests of the community. Our goal is to strengthen collaboration across the kidney community and ultimately support better outcomes for the patients that we serve. Just a few little meeting guidelines before we dive into the presentation. Everybody was muted upon entry into the call today, but we want to hear from you, like I said earlier, so please drop any questions into the chat or concerns or sharing of best practices or any ideas. This call is being recorded, and the presentation materials will be shared following this webinar. So we want to start off with a polling question. So Laura, if you can go ahead and launch that. We'll get that started. But the polling question to get us started is, how familiar are you with immediate start peritoneal dialysis? Somewhat familiar, heard of it, but not familiar, or you're not familiar at all with that? So we're getting quite a few votes in, and we're getting up there. We're going to give everybody another minute to answer that. Looks like quite a few people are using the chat, and that's okay too if you're not able to utilize the poll. So, okay, I think we'll go ahead, if you will, and close it, and then Laura Menken, if you can share our results out with everybody.
Sure, I'd be happy to. Thank you, everybody, for responding. It looks like we have about 65% of our attendees today were somewhat familiar, and then just a few fewer just have heard of it, but not super familiar. So sounds like we have some great learning to do today.
Right. Thank you. Thank you, everybody. So we'll move on for today's presentation. Today's presentation is Dr. Michael Galicchio. He's a board-certified general surgeon and fellow of the American College of Surgeons with expertise in transplantation and dialysis access care. Dr. Galluccio has held faculty and surgical roles at Albany Medical Center, the University of Alabama at Birmingham, and Birmingham Veterans Administration Hospital. He is a member of several professional societies, including the American College of Surgeons and the American Society of Transplantation, and is the founding member of the Vascular Access Society of the Americas. He has authored numerous publications and presented nationally and internationally on transplantation and access care. In South Carolina, he co-founded the Dialysis Access Institute with Dr. John Ross, where they perform thousands of procedures annually and advanced physicians' education in dialysis access placement, maintenance, and salvage. Currently, Dr. Galluccio resides in Albany, New York, where he provides dialysis access care to patients at Capital District Renal Physicians. So I'm going to turn this over to Dr. Galluccio.
Thank you for that very kind introduction. It's somewhat humbling when I get to hear that, but also a little bit disconcerting as I'm getting older and older. Many people have heard of immediate use techniques or immediate PD. However, the vast majority of people who think immediate use or immediate PD are thinking usually in-hospital peritoneal dialysis, usually low-volume peritoneal dialysis, usually lying flat on a table for hours on end peritoneal dialysis with the hopes that it won't leak. Roughly 20% of the time it does. And many of the surgeons that I've ever spoken to say, yeah, I have a technique that we can. And I say, well, how many times have you ever done it? And generally the answer is, well, never, because I've never really ever been asked to do it. That's another part of this. This is not actually just a technique. This is actually a system. That's why we called it seamless. Dr. Carcillo and I came up with that. Really, Vince did. He's more of the brains and I'm the brawn of the group. And we came up with an idea to be able to use the catheter full volume, upright, outpatient. Next slide. So who are the patients that we can put the seamless catheter in? Well, it turns out, in general, anybody who you're considering doing peritoneal dialysis is a general candidate for this. Laparoscopic assistance can be employed if necessary, particularly in those people who have had pelvic surgery, such as hysterectomy, diverticulitis surgery, sigmoid resection, where you really don't want to be placing the catheter blindly otherwise. In the, quote, virgin abdomen or non-pelvic operated upon abdomen, this can be done as an open technique. As you can see, a left paramedian periumbilical exposure is performed. It can generally be done preferably under general anesthesia because of the muscle splitting technique I employ, but even judicious use of monitored anesthesia care and the severely or critically ill or severely pulmonary compromised individual can be done. And you do not have to stop the chronic anticoagulation that everybody seems to be on these days, which includes Eliquis or Coumadin or Plavix. Next slide. I do a paramedian incision, extend it down towards the pelvis. Generally, it's going to be on the left side simply because I'm going to be going left to right, avoiding the curvature of the sigmoid colon. Once I enter the anterior rectus sheath, I will then split the muscle and then get to the posterior sheath and peritoneum. The paramedian incision helps avoid the midline structures that will always be there. There's always a little bit of preperitoneal fat that you'll encounter. It's not that big of a problem. The posterior sheath fascia above the linea semilunaris is generally sturdy enough, and just about everybody, even those on corticosteroids, that has the holding strength to hold the purse string suture. I place. And even at extremes of age or the significantly obese, when you get above the linea semilunaris, that fascia tends to be good enough. And the abdominal pressure tends not to be so great that I'd worry about it not being able to hold. Next slide. These are pictures of what normally are videos of the technique. As you're looking at it in the top left corner, you can see the exposure that was performed, where I'm now down upon the linea, the anterior rectus sheath. I then split the anterior rectus sheath with cautery, and I open the fascia along the entire length, and then I split the muscle, and I can utilize cautery for any perforator bleeders or anything else that is an issue. I go to the very inferiormost, bottommost portion of the incision, and that's where I'm going to make the peritoneotomy and the posterior sheath entrance, so I can get as low down as possible, and then utilize the split area as the seat for where the Missouri catheter is going to be sitting. Next slide. The Missouri catheter has actually been around for a very long time. It was invented in the University of Missouri. It's made by Covidien. It's got some problems. It's the reason why most people who put PD catheters in don't ever use them. And I was one of them. A mentor and friend, Dr. John Ross, who he really did establish the DAI. He used them, but there was a lot of dysfunction because the catheter naturally wanted to flip out of the pelvis into the mid-abdomen, or would peristalsis and then be in the mid-abdomen. And I just kind of worked on using that problem to make it less disadvantageous. The ball and flange is much better seal than the standard tank-off catheter, where you're relying on trying to get tissue that isn't going to move, isn't going to slide, to approximate on the standard cuff that you might see in tank-off. It's really never a perfect seal, and it's always the crux of why people who say, yeah, I have a technique, always hedge their bets and say, well, I never really did it, or let's not use full volumes because I don't really want it to leak. The Missouri catheter, and usually if I'm presenting this in person, I have in my hand a Missouri catheter. It's also got a right angle angulation, which again, it's just the way it was designed. I overcome it by basically turning it from this way to this way. And by doing that, I make it work better, make it work as an advantage for us, guiding it towards the pelvis and directing it towards the pelvis and making it want to be in the pelvis, as opposed to making it want to migrate outside the abdomen, outside of the pelvis and the abdomen. Next slide. So as you can see on the, again, top left, as you can see, there's a curvature, and you use a stringer to straighten it out. And now I can then guide it towards the pelvis, and that's the bottom left picture. And you can see that the four pictures on the right, by orienting it in the appropriate manner, the catheter tip is going to be going towards the pelvis, and the tip, the ball and flange, will then want it to stay there. Next slide. So these are a little bit more difficult to see in single slides, but what I've basically done is I've opened up the posterior sheath. I've got a purse string on it, and now I'm going to be able to guide the catheter into the pelvis. This, by the way, is where you can take a 5mm balloon port, cinch the purse string around the balloon port, fill the abdomen full of CO2, and with a 5mm laparoscope, you can look around if you need to do a laparoscopic aided PD exposure, PD placement, and then take that out and still have the purse string available to then put the catheter in once you know exactly where you're going to guide it, or once you know that there are not adhesions, or you have the actual direction you want to guide the catheter. So that is actually one of the advantages. Next slide. So as you're looking at, left has the catheter stringing. On the right is actually an interesting one. This was someone who theoretically didn't have any surgery, but they had an adhesion. And I got a little bit lucky, and the catheter was actually able to be right above the adhesion and threaded into the pelvis. You can see at what would be 10:30-ish or 10 o'clock-ish, the white of the ball, and then the flange is there. And you can see that the catheter wants to be in the pelvis. This was an individual who was having some pelvic pain. And what I did was I put a stay suture, you can see about 3 inches down, and I tacked the catheter up to make sure the tip was completely not poking into the pelvis, just to relieve some of the pain that the person was experiencing. This is someone who had had the PD catheter in for over a year, and that was what I found. I found that kind of interesting. And maybe that adhesion had formed since I placed the catheter, but nonetheless, it was all kind of cool. Next. So this is the PD catheter. And so on the right, you can see that it's not very long between what looks like, I call it a hat, and the ball, and then that forced curvature, and then the subcutaneous cuff. What I do is, instead of it inserting directly, I turn it on its side so that what is upright is actually lying flat on the posterior sheath. That forces the catheter to want to stay straight into the pelvis and wants it to actually be that direction all the time. And that's really the key to this. Other than getting the purse string correct, and other than having the muscle kind of seal everything up so that even if there's a microscopic leak, the muscle will tend to absorb it or prevent it from being a full leak, just turning it on its side is the, I like to think, elegant solution to the problem. And it works. Next slide. So I'm now seating it in the top left. And again, these are, again, videos that are now just captures. And I'm tying the purse string. I actually have learned that if you come from inferior most with the purse string and you're holding it superior most, that's where it's easiest to tie it. The catheter then sits perfectly on the posterior sheath with the angle then coming up much like a chimney. And then when you close the fascia overlying it, there's a little space, 1.5 inches, 2 inches up, where the catheter is coming out well away from where the entrance is. And by the separation, again, you create almost a flat valve functionality of the tissue to, again, try to prevent even microscopic or macroscopic leakage. Next slide. So I'm closing the fascia over, and it's again I interrupt it. It makes me feel more comfortable. Plus, I always close the fascia both above and below the exit site, and those are the stitches. And I use magnification whenever I'm sewing. Those are the stitches that enable me to see and get that seal. It's based off of my experience when I did ureteroneocystostomies in the form of the Minnesota 1 stitch, where you tacked one into the bladder, and then you close the muscle over it. You always needed to close both sides, but not super tight so you don't create a stenosis. The same thing. So you close the interrupted fascia, you close it from above and below. It comes straight out. Now it's coming straight out, and then it wants to curve over, and you can flop it over. And then you see, once the fascia is closed, the only thing that's sitting there is that subcutaneous cuff that's ready to be then brought out laterally like the standard peritoneal dialysis catheter. Next slide. I create a little pocket so that there's no pressure on the catheter so that I prevent any possible kinking. You can see that I'm creating the subcu pocket so that the cuff sits in the pocket. That's the top left. And then I use a sharp trocar, which is the exact diameter of the catheter to try to get the best seal. And then I bring it out superolaterally. And then I close up the subcutaneous tissue, taking care not to kink or stick the catheter. And then I run the skin with a running stitch. And you really can't see it, but it's really kind of fun on the video, what you can actually see. Next slide. That's the closure, and actually the catheter is dripping fluid, and I run it in and I run out fluid. This is a very old, these are very old images from one of the original ones that I did. And you can see that I was so paranoid about infection, et cetera, that I actually had a plastic sheath. I don't have that. I don't have that anymore. You don't need that. I think it increases the risk that I'm going to yank on the catheter and accidentally pull on it, which I don't want to do. So you do the closure. I run the stitch. I even put glue on it. And the reason I did glue is that the first half dozen or so patients had such anasarca preoperatively that I was afraid that the catheter not leak would be mistaken because of the leakage of the subcutaneous tissue anasarca. So I sealed it up the best I could, which was a running baseball stitch and then skin glue. And all of that, the stitches are taken out at 3 weeks. Next slide. Okay. And as you can see, there's the pelvis with the pelvic wings for the bladder. I stay lateral to that, but you can see even in someone relatively thin, there is always potential for some preperitoneal fat, and you might enter it because, again, you're coming in without knowing the benefit of seeing what I'm seeing from inside. But that's not a big deal because, again, we're really just closing the posterior sheath. And you can see above the linea semilunaris, that posterior sheath has some pretty good integrity and holds very well for the purse string. The purse string is always a 2-O-proline. Close the fascia with interrupted ovicrals, the subcu with interrupted, or excuse me, a running 3-ovicral, and the skin a running 3-O-proline. Next slide. And you can see me putting on the skin glue only because I'm very superstitious. And that should be about it for the technique. Anybody who's a surgeon, I believe, that's general surgery trained can do this. And I don't believe that it requires exceptional surgical skills. I think I came up with the idea of turning the Missouri catheter around, and that's the solution to taking a catheter that theoretically is great to use, but not, and making it functionally something very straightforward to use.
Thank you very much, Dr. Gluccio, for that. That is so exciting. That's very interesting. Just as a reminder to everybody, please drop any questions or comments that you have into the chat. We'd really like to hear from you. And I'm going to kick us off with just, if you could share with us, how many of these procedures have you done?
104.
104.
104. And all of them have worked. And so far, no leaks.
That's really good. That's very positive. I just wanted to say there was a couple, I think when we were doing the poll, I did want to say somebody dropped in that says somebody in Virginia Beach area is regularly using this exact same procedure. So there's somebody doing it. It may not be exactly, but there's another question.
I've done some lectures. We did travel pre-COVID. And we did do some lectures, and I would be hopeful that maybe that person, or I've spoken to them, because this isn't something I hide. This is something that I would talk to anybody and everybody about, and that's awesome. I hope they're having the same success I am.
Well, the questions are coming in now fast and furious, so I'm going to try to keep up with some. Somebody did ask, how large is the incision, the actual incision?
It's about the length of your pointer finger from the start of your hand to the tip. And
Okay.
it doesn't have to be much longer than that, because it doesn't.
Okay. Uh, a question would be, what would be the best way to get our surgeons trained? Somebody is,
Either have them contact me so that I could go over it, or if you're in a place that has a really good golf course, I'm an avid golfer, I'm glad to come down and visit with my golf clubs.
perfect, perfect. Another kind of question. So if we notice leaks, does this mean we need to immediately stop use?
So you have to be certain that it truly is a PD fluid leak, because the vast majority of the patients that you're doing this on, this is emergency or urgent emergent start. They're usually fluid overloaded. And there's always the violation of the skin. So a lot of times the fluid coming out of the exit site, if there is any, is serous fluid. It's actually third space fluid, or it's actually it's interstitial fluid, not PD fluid. But my plan has always been to shut it down, let it heal for a week, and then restart and retry. But again, we haven't had one yet. And I use the word yet because I don't have so much of an ego to say it's never going to happen. Anybody who says never hasn't either done enough or hasn't been around long enough or is lying to you. But so far, not yet. But that would be what I would do, is I would shut it down for a week.
Okay, sure, thank you. I'd love to know where Chantil's from. She says, we have 9 trauma surgeons that put ours in, and they are really, they're really engaged, the surgeons. So I'd be interested in what area she came from, but
That's
good to hear it.
excellent.
Yeah.
And they're
Questions
very,
about volume.
again, they're very facile in the abdomen, and I'm sure they're used to open, because laparotomies, and that, because what's happening now is a lot of the people trained, if you're not sticking a port in the body, you're not familiar with what you're doing. So it's nice to have people who understand what midline is.
I was just saying, Stephanie, I've seen a couple questions around volume after the
Full
placement.
volume upright.
Full
Full
volume.
volume, 2.5 liters, full volume upright. In fact, I want them sitting up, because I want all that fluid into the pelvis, and I want them doing the exchanges.
And they can
In
do
fact-
all their exchanges in a day. Everything's just like being trained on. So do you train the patients before they get their catheter to start PD? Does that happen in the clinic? How does that work?
So not necessarily before patients being trained, but the staff. So this has been this wasn't done last year. This has been done for 6, 7, 8 years. Originally, and this is what's kind of funny, the original one, or number 2 or number 3 that we put in, the second or third one that we put in, they had the person lying flat, and it was draining really slowly. And I got a phone call from Vince that they're worried it's draining slowly. I said, sit them up. I want them upright. They don't have to lie flat. Get them upright. And they sat the guy up, and the thing immediately started draining extremely well. So they can do, the plan is to do it full volume, whatever exchange, whatever. And it's the dialysis unit, the home training unit, that has to have the most buy-in. They're the ones who have to believe in what you're doing, because otherwise they're going to be very timid or reluctant. And success begets success. When the first few worked like a charm, and the patients didn't have a perm cath, and the patients were on PD, when they would have, historically, they would have ended up in the hospital because they're fluid overloaded and they need emergent dialysis, and then they get a perm cath, and then you don't see them for a month and a half, and then everybody's wondering, and then they've had their first perm cath infection, and next thing you know is they don't ever see PD. These individuals never see hemo, or they were on hemo and something's lost and they want to do PD, such as one of the patients that we use as kind of an exemplar. This was a guy who was doing home hemo. He infiltrated his fistula pretty badly. Arm was swollen like a leg, but he was on the cardiac transplant waiting list because he had cardiomyopathy. And the transplant unit told him that if he had a perm cath in, he would be put on hold and would have to get his perm cath out. So he did PD for about 3 or 4 months while his arm completely healed. And then they started using it again. And when it was completely working and the buttonholes were back working, we actually took the PD catheter out. He never went on hold. He never actually had to stop dialyzing, and he dialyzed effectively. In fact, the transplant center called him up because they didn't believe that he was dialyzing effectively. They thought it was low volume, flat. And when he came in and he showed him the catheter, he showed him that he's doing full volumes, they were astonished. That worked.
Right. Here's a good question. Can this be used with pediatric patients or only adults?
I think anybody can do it. I think you can. Pediatric patients, that Missouri catheter, I don't know if they have a pediatric version of the Missouri catheter. So you might struggle a skosh with the presence of the catheter pushing up a little bit. But because the fascia is pretty intact, I would suspect that, yeah, you can. You may have to, I might not put it, again, I would have to eye and measure it. I might not put it at the very low end of the incision. I would measure it out to see where the tip is going to be so that I'm not banging into the child's bladder or rectum so that you're not getting pelvic pain. But I've done this on very small adults and it's worked very, very well. I had one woman who used it, for 6-7 years, just recently passed away, who had scleroderma, and she was maybe, she was about 4'10", and she did perfectly well, but she was a small adult. I can't say I've done it in a child, but depending on the size of the child, I'd be willing to do it. Yes. But I can't say, in my ample, vast experience, it's been done.
Great. There was a couple questions that are coming up the same, and I just want to take a quick second to, yes, the PDF of these slides and the recording will be sent out to everybody who is on the call today. So some of them want to share it with their nephrologists and surgeons. So great. Yes, you'll be getting those within the next day. So
and I've also got videos. I would even share the videos. Like, I don't have to share the presentation, but the videos that are part of the presentation, those videos are a little bit better explanatory. The problem is that made the presentation 1.6 gigabytes. And I guess that doesn't work for the server.
Yeah. And a couple more, we still have some time, so there's some questions. So what would be the reason for this catheter versus going straight to a hemo catheter? Just keeping the patient out of the hemo chair or to stay away from infection on the catheter, in a hemo catheter?
Staying away from hemodialysis and a perm cath. I mean, that's fistula first, catheter last. And the other thing that happens is that the data is such, or at least what we saw, is that if you put a perm cath in someone and they said initially they wanted to do PD, there is an appreciable number of people who then do not go on to PD. And so if you want to optimize home therapies and you want to optimize PD, don't ever introduce them to a perm cath.
Absolutely. Is this technique better for CAPD rather than overnight ADP? Any preference?
No, both work great.
Okay, perfect.
Yeah, you can. Most of our patients, all of our patients are trained in manual exchanges, and then the vast majority of them are on the cycler.
Okay. Another good question in here, is there a difference in the cost of this product and technique versus what is typically used? How can we support patients with interest in PD but insurance limitations?
No, it's a standard. In fact, actually, one of the insurance companies in the area would benefit. So it's a surgical technique, and it's actually cheaper because the equipment you use is not laparoscopic equipment. The operation takes about the same amount of time. You could do pure percutaneous laparoscopy that might take a bit faster, would be a bit faster, but the equipment utilized when using laparoscopic equipment is always more expensive. But the expense that the insurance companies look at is that if you have someone who is crashing into dialysis and they end up with a perm cath and a 3 or 4 day hospitalization, that cost is far, far greater than doing an outpatient elective PD catheter. So we have complete buy-in by all of the insurance companies, particularly if we keep them out of the hospital.
Right.
So one of the early patients that we had was a guy who showed up because he really was lost to follow-up, and he showed up to his primary's office and he had a creatinine of 9 and a BUN of 120 and thought he had the flu. He wasn't hyperkalemic. He wasn't particularly sick. He got sent into the ER. Vince happened to be on call, started talking to the guy. He thought he wanted to do PD. We were able to get the home training point person to come in and talk to him in the emergency room. I saw him. They discharged him Friday evening. He was on the schedule Monday morning, got his PD catheter first case Monday morning, and actually got his first dialysis Monday afternoon with the new PD catheter. Now, that's why this isn't just a technique. This is a system that Vince and I, and really Vince very much, the portion of that, we got this technique to be able to do it. That enables us to reliably do it. But the other moving parts of getting the PD, the nephrologist, cardiac clearances, anesthesiologists that will put these individuals to sleep with the cardiac clearance, that was all the things that we worked on to make all of this happen successfully.
All right, thank you. We got like maybe 2 or 3 more minutes, and there's just a few others that have come in. I think you addressed this, but one, let me just bring it back up. Do they need to be supine during the first couple of weeks?
Upright.
And then do you have any drain issues with CCPD while they are laying flat sleeping?
Haven't yet.
Okay.
No, can't think of any. I know I had the one person who was having the pelvic pain. You can see that one. But that was later. That was again a year later, or 9 months later. No, so far it's been really pretty solid. Now,
Okay.
I have ways of addressing that. Just as if I do laparoscopic surgery too. I put in laparoscopic PD catheters all the time. Also, those are more the ones where I have a nephrologist who says, "Well, no, this isn't urgent emergent. He's not ready to really want to start for another month. Let's just do it the standard way." Or if I have someone who's had multiple abdominal surgeries, I do get a fair number of referrals who are complex abdomens, where I got to get in and figure out, can I come in from the sides, or, what do I do? I've had multiple hernia repairs. Now everybody who gets a hernia repair, it has mesh used and gets their abdomen violated. So I put in a lot of laparoscopic, and I would address it laparoscopically as if it was a laparoscopic PD catheter.
Well, speaking of that, then here's a question. It says, what, if any, technical changes are needed in laparoscopic placement of this catheter?
You can't. You can view it assisted, but you have to do the cut down because you have to put the purse string in at the ball and flange, and that has to be done open. And you have to separate the muscle. Those are the things that are so that you get the catheter to sit correctly. So those are the things that are non-negotiable. So it's going to be an open technique. Now, it can be laparoscopically assisted if you're trying to expand from the abdomen that's potentially hostile. You can always do it that way, but it's always an open technique.
Okay.
Because the two things you have to do is the purse string and the seating of the right angle flat on the posterior sheath.
Well, I think we covered, if there's anybody sees anything that I just missed, I tried to keep up with them. There was a lot of good conversation, actually I'm kind of impressed to see some people are using it out there. And the one gal that, said she had 9 surgeons, she's in Springfield, Missouri. So,
Well,
using it
they're
there.
the home
Yeah.
of the or Columbia,
Yep,
as I
so,
guess. But they
not
probably use
surprised.
it there in a number of Missouris.
Yeah. So
Well,
thank you for all that. That is great. Some great questions out there, great engagement from the participants. I do want to, again, be conscious of our time. I do want to kind of go to like a polling question now that everybody has heard this presentation. We want to go ahead and launch the poll. Thank you. What do you think is the biggest potential benefit of the ISPD for patients with sudden kidney failure? But actually, Dr. Glucci, what you said, some of them were already been thinking about it months ahead. So it's not always just,
Well, it's evolved.
yeah,
Because there's ideally a patient starts PD in a elective manner. The problem is that's not always the case.
exactly.
And so you've got to be ready to do that. And, the proof of concept is there for my group. So my group believes in it. My group has 8, 9 nephrologists. So some like PD more than others. Some are more comfortable with this than others. Some want to utilize me to talk things through early. Some just want to call me when and if it's ever necessary. So it's, there's a lot of different perspectives, and I'm always ready to kind of take those on.
Okay. Well, it looks like we've got quite a few votes coming in. I think we'll go ahead and close it. And if Laura, you can share with us again the results that you got.
Sure, be happy to. It looks like the majority of our respondents determined that option number 1, avoiding emergency hemodialysis, was probably the best benefit at about 45%. Coming in a close second, increasing home dialysis initiations from CKD was about 25% of our respondents. We did still have 1% say they're not sure, and the remainder said reducing delays in treatment and starting dialysis at home sooner.
I'm sure the 1%. It wasn't that they're not sure whether or not there's going to be a benefit, but they didn't know whether 1 or 3 was the best answer. So they were. I'm joking.
There is a
Great.
question about the recurving PD catheter. Did you see that one, Stephanie? If we have a minute left.
Yeah, it's yes, it's do curving the PD catheter reduce flow than straightened catheter, or is it just for anchoring?
The catheter is naturally curved that way. That's not me curving it. That's the way the catheter is manufactured.
Okay.
So it doesn't affect the fluid. It doesn't affect the drainage. It's actually is A-okay. You have to remember that, in the abdomen, it's 3-dimensional movement. So if you truly believe when you put in something laparoscopically that there is an angulation, you're fooling yourself. But what you want is you don't want bends. You don't want kinks. And by the way I put it in and I bring it out in a natural curves that way work extremely well.
And is it on the slide somewhere, Stephanie, Dr. Galuccio's contact information? Is that a part of the slide set? Because a couple of people asked if they could have his direct contacts. They want to connect with him.
I don't think it's on the slides, but I'd be glad you can share it.
Dr. Galuccio, I can send that out if you don't mind, your email with the slide deck and
you can even
recording.
Yeah,
is that okay?
And you can here's my cell phone number.
Oh dear.
He's very accessible. I love it.
Go ahead.
518-396-0178.
You want to repeat that just because some people might be writing it down?
518-396-0178.
Perfect. I'm sure they're writing that down, but I will include that plus your email address, because there was a lot saying, how can we get some of our people, our surgeons, I'm living in a rural area. Can we share this? So that would be great.
We'd
Thank
be
you,
glad
Laura,
to talk
for putting
to them
that in
or
there.
do whatever.
Yeah. I just want to give a shout out for the CARE social media here. We are on Facebook, Instagram, X, and LinkedIn. So please start connecting with us, like us, follow us. We would really appreciate that. And I think the last slide is just thank you again for attending. You will, with the conclusion of this conference, once I close it, you'll be prompted to fill out a little feedback. We'd love to hear from you. Like we mentioned earlier on the call, we want to hear how well we did, what we can improve, what kind of topics you would be interested in, and for the community that we can look forward. Again, these will be occurring monthly. So we're always looking for speakers, topics. We really want to hear from you. So I just want to thank everybody again, Dr. Galuccio taking time out of your day, CMS for joining the call, everybody, all the participants today. I think it was a great presentation, great dialogue, a lot of good feedback, and a lot of good questions. So thank you again for everything, and just take care. Have a good rest of your day. Thank you,
Thank you.
everybody.
And thank you for giving me your time and listening to me drone on something.
Oh,
That was excellent.
it was great. Very interesting. I even learned something. So it's always good. So appreciate it. We're going to
My pleasure,
conclude our
truly.
call now. Thank you